Hello, this is Cheryl Westfall, and I have the privilege of presenting cultural competence in the delivery of dental health care. As your presenter this evening, I will go through a series of slides with you. I will bring you to some polling questions, and at the end of this presentation, there will be time for question and answers. I'm an Assistant Dean for Allied Health Programs at New York University in the College of Dentistry and the Director of the Dental Hygiene Program there. I also have had the opportunities to publish on cultural competency, and it's an extreme interest of mine, so I hope you enjoy this presentation. By all means, take notes and take time to write some questions if there's some interesting ideas that you would like to share at the end. Our U.S. population is changing, with an increase in minority populations. According to the U.S. Census Bureau, the Hispanic population grew by 43% from 2000 to 2010 and comprises 16% of the total U.S. population. The non-Hispanic population grew only 5% over the last decade. More than half of the growth of the total population of the U.S. between 2000 and 2010 was due to an increase in the Hispanic population. The Asian race grew by 43%, and Black or African American also grew by 12.3%. The white alone category actually declined over a 10-year period from 69% to 64% of the total population. However, our dental and dental hygiene graduates still represent a majority of white professionals, and for dental hygiene, mostly white female professionals. Even with efforts to attract more diverse candidates to our educational programs, we as a profession still fall far short from representing the minority populations we hope to serve. Therefore, we must learn to practice cross-culturally to be able to address each of the cultures in our practices and our communities. This presentation will provide an overview to get you started with a review of definitions and then some practice examples for our process of care. The lecture objectives for this presentation are to define culture, cultural competence, cultural sensitivity, differentiate race and ethnicity, discuss cultural barriers to communication, discuss how culture relates to the delivery of dental care, and to describe how cultural and linguistic competencies can be attained. I hope you will gain from each of these lecture objectives. What is cultural competence? According to Kapikina Bakot, the framework of cultural competence begins with understanding 5 interdependent constructs for competence. These are cultural awareness, cultural knowledge, cultural skill, cultural encounters, and cultural desire. The 5 constructs together bring us to cultural competence. Cultural awareness is the ability to appreciate the client's values, beliefs, life ways, practices, and problem-solving strategies. It's important to begin with understanding your own beliefs and cultural background to see where the differences lie. Cultural knowledge is the ability to have insight and knowledge about physical, physiologic, biologic variations among groups as well as cultures. As we continue, cultural skill is the ability of healthcare providers to conduct an accurate history and physical examination. Cultural encounters is the ability to competently work directly with clients of other cultures using verbal and nonverbal communication. Cultural desire is the ability of the practitioner to possess a drive and a motivation to achieve cultural competence. Our goal is to reach cultural competence, to understand these differences, and have mutual respect for each culture. Cultural competence is further defined by understanding the terms cultural and linguistic competence. This is a set of congruent behaviors, attitudes, and policies that come together in a system, agency, or among professionals that enables effective work in cross-cultural situations. Class, as it is referred to, are a set of cultural and linguistic appropriate services, mandates, and guidelines issued by the United States Department of Health and Human Services. In addition, culture is defined as integrated patterns of behavior that include language, thoughts, communication, actions, customs, beliefs, values, and institutions of racial, ethnic, religious, or social groups. Looking in more detail, culture is integrated characteristics of a group of people over a given time. It is values, beliefs, attitudes, customs, and rituals. It is shared by the group, and it is passed on from generation to generation. One's perception of health depends on culture and may differ from the provider's perception. Let's stop to review. If we have awareness and knowledge of our client's culture, we know what their background is and how it relates to healthcare beliefs and practices. We also have the knowledge to take health or dental health histories by asking properly phrased questions which might relate to their culture. We have the desire to learn this new information and apply it to our practices, and we have some encounters or experiences with different groups to be able to learn and practice these skills to reach competence. In addition, we have linguistic competence as it relates to various cultures. We have made sure our words, literature, explanation, signage, and directions reach the level and understanding needs for each client of each culture. Diversity is the concept of being different or having differences. This can be gender, sexual orientation, age, physical or mental disabilities, socioeconomic status, religion, or location. All of these concepts are important to the delivery of dental and dental hygiene care, yet this presentation will focus on cultural differences. As said earlier, our workforce is not as diverse as the populations we are trying to serve. Increasing the diversity of our practicing professionals is one way to bring closer understanding of the cultures we serve. However, there will always be a Chinese dental hygienist providing care to an Arab client, or a Caribbean Islander professional providing care to white clients. When diversity in the workforce does not match the patient population, we must learn to practice cross-culturally. Race and ethnicity are two terms easily confused. Race is a classification of human beings based on physical characteristics such as skin color, facial shape, stature, or other inherited characteristics. The races used by the U.S. Census currently are American Indian Alaskan Native, Asian, Black or African American, Native Hawaiian or Pacific Islander, white, or multiracial or some other race. Ethnicity refers to the individual or group's conception of cultural identity, which includes a variety of learned behaviors. Hispanic is an ethnicity, not a race. One can be white Hispanic or black Hispanic. White and black are racial identity, and Hispanic is an ethnicity. It is important to distinguish race and ethnicity, and then relate ethnicity to culture. Race is too general for us to apply to the process of care. As an example, according to the U.S. Census Bureau, white refers to a person having origins in any of the original peoples of Europe, Middle East, North Africa. It includes people who indicate their race as white, but yet also identify as Irish, German, Italian, Lebanese, Arab, Moroccan, or Caucasian. In the U.S., our white population might also identify with Amish, Mormon, or Hasidic. Ethnic groups share common factors such as language, music, food preferences, religion, or health practices. Each of these groups holds a very unique and identified culture. Therefore, we would say that they are Irish or Irish American, describing their culture more than their nationality of where they were born or hold citizenship. Hispanic or Latino may be of any race. Hispanic or Latino are those people who classify themselves in one of the Spanish, Hispanic, Latino categories of the U.S. Census, namely Mexican, Mexican American, Chicano, Puerto Rican, Cuban, or other. Other Hispanic, Spanish, Latino are those persons from Spain, the Spanish-speaking countries of Central and South America, or Dominican Republic. Additionally, Hispanics derive from mostly the white Iberian Peninsula of Spain or Portugal. Latino descendants from brown indigenous Indians of the American south of the United States, and the Caribbean who conquered Spain. I'd like to stop and do a polling question. Our first polling question is on race. What race do you think an Arab represents? I can see that not all of you participated, but you can see from the presentation that your votes have come in as 7.5% Asian, 40% white, 7.5% believe it's black, and 45% believe it's Arabic. In actuality, the race of someone from an Arab nation or an Arab country would still be white. Their ethnicity would be from an Arabic country, and then their culture would relate more specifically to the actual country of where they reside. You can see from that poll that it is easy to confuse race and ethnicity. Now let's look at stereotyping. Stereotyping is an extremely important concept. It is the erroneous failure to recognize individuals as unique. There are differences even within the norms of a culture or the creation of a subculture, such as age, for instance, or location, such as Los Angeles or the differences of New York City. It is inappropriate to make assumptions about a person's ability, knowledge, values, or beliefs. Have you ever been stereotyped, and how did it make you feel? Stereotypes can be both negative and positive. As an example, someone might hold a stereotype that Asians are exceptional at math. This stereotype could place undue image or pressure on an individual of Asian descent if they personally did not do well in math, and the expectation was that they should do well. A negative example is the case of Rosita. Listen to this scenario. Rosita is Hispanic and is new to the dental practice. She had difficulty understanding the directions to arrive at the practice and arrives 20 minutes late for her appointment. The receptionist greets Rosita and states, "You are late, and you are not on Cuban time anymore." Consider this impact to a new patient. Although it might be said, in general, a Hispanic or Latino time orientation might view time as relative or elastic, this comment made the assumption that Rosita was taking advantage of time and chose to be late. The receptionist did not consider other possible reasons for lateness and immediately imposed a negative stereotype based on this person's ethnicity. Cultural sensitivity is another aspect to consider. Cultural sensitivity refers to making an effort to understand language, culture, and behaviors of diverse groups. It is an awareness of and a respect for patients' cultural beliefs and values. The practitioner must recognize that diverse populations exist in our country, as well as from country to country. The individual needs are foremost, and the practitioner should be able to view each culture individually, without acting ethnocentric, believing that our own culture is superior. We must be able to accept differences without stereotyping. Here is an example of a dental hygienist as the practitioner in this case. This dental hygienist would recognize that a patient from Africa, Asia, or the Middle East might use a miswax stick as their traditional aid for interdental cleaning. Being sensitive to this behavior is a required aspect of our care. What are some barriers to access of care? People from different cultures have difficulty accessing care. One concept that has been reported is that people seek care from practitioners of a similar culture. There are many aspects to be considered in cross-culturally practicing. Income can have a major impact on access if the patient cannot afford care, is not covered by insurance, or comes from a country where care was nationally covered and now does not have insurance. There are also considerations of cost of travel to a provider who has similar culture or speaks the same language. Healthcare literacy is often a factor. If the language barriers, or if in translation certain terms are not understood, language can create the barrier to accessing care. Health beliefs of different cultural groups may be a factor if a culture does not believe in dental health care and fatalistically believes the teeth will fall out anyway, or if they cannot afford care and choose to use the income in other means. If you are providing care to a low socioeconomic client, it's extremely important to consider access to the services and the cost of preventive products that you're recommending. It could be embarrassing for a client to state that they cannot afford the toothbrush or toothpaste. As an interesting side note, while trying to explain why a client needed to rinse and expirate the mouthwash, the client could not believe why they would spit out such a valuable and costly product. What are some suggestions to understanding cultures? The first step is to learn the differences in our client and our community populations. This could mean that the dental professional needs to learn non-traditional or herbal medicine. It could also mean understanding more holistic or non-Western medicine, as well as the Western medicine that might have been part of our formal educational base. The actual health beliefs, which follow a given culture, should be assessed. Each time a dental professional will learn what is different from their personal belief or practice. We must have a broad understanding of cultural nuances. Think about the melting pot concept. In this concept, a patient gives up their cultural identity and assimilates to the given country or current location. Instead, the concept of a salad bowl could exist, where a client holds their cultural identity. The culture of the client therefore will influence the health status, beliefs, and behaviors. What will we say to a client who believes healing is through mediums and not just the actions of the client? If the majority of the world holds a non-Western medical philosophy, each of us needs to assess beliefs and practices with this view. The use of fluoride in our products may not be permissible and recognized in certain cultures. And what will we do to accommodate? We are now going to look at integrating culture into the process of care. We need to think about each step as we go along this process. We will look at each one of these steps individually and address how to adapt our process to the cultures we are serving. The first area we're going to look at is assessment. As we consider the personal health and dental health histories, what aspects of gathering data and interpreting data become important in a given culture? As we do extra and intraoral examinations, what limits might we have for the cultural courtesies, the protocols, or the beliefs? Consider if there is a family or heritage information you need to gather. Is the health history based on Western, non-Western, herbal, or holistic care? Was the dental history a factor of access to care, a health belief, or a lifestyle? Each of these aspects should become questions or data gathering part as we look to our normal routines for assessment. As an example, our Black or African American cultural group has a high incidence for hypertension and diabetes. While asking questions of this client, the dental professional would be certain to delve into questions of nutrition, blood pressure, caries history, obesity for this particular cultural group. The dental professional performing a head and neck examination for a woman wearing a burqa or headscarf might need to explain in more detail the need for thorough palpation of the regions covered by the dress and inform the client how to do a self-examination or how to have another person assist them in the privacy of their home. Cultural assessment includes gathering information about ethnic origins, places of residence, values, customs, beliefs, practices, dietary practices, and other socioeconomic factors related to the culture. First, always know how to greet someone. A misunderstood handshake might set the tone for the whole encounter in the wrong direction. Sometimes adding questions to our normal medical and dental forms will help the dental professional remember to gather this information. Early discussions with the client can begin to establish a common ground for further detailed understanding. Diagnosis and prognosis are the next steps in our process of care. For the dental professional, while doing a dental hygiene diagnosis, we'll consider any common health problems for this given culture. In doing so, the assessment questions might become more detailed for certain disease states to ascertain if conditions exist or could exist. Cultural health beliefs and practices might influence the prognosis of a finding. Does the client have a health belief or desired action to address the concern? Does the client have access and socioeconomic ability to reach a favorable outcome? Is the high caries rate due to a health belief, lack of a skill, or lack of access? Are the providers in the community available for this need? And what are the other culturally sensitive actions to be considered? Caries has a high incidence in Native American and Alaska Natives. In considering this fact, the dental professional would need to address access to care of this particular geographic location for providers, access to preventive products, the lifestyle, and diet when addressing the prognosis of this problem. It's not merely a factor of improving brushing and flossing. This is also true of Mexican Americans and Black non-Hispanic populations. Let's stop and do another polling question. We'll do a polling question on health beliefs. What would you do if the client, for health beliefs, did not wish to have fluoride? You can see from the results that most of you did select planned caries risk reduction with other interventions. The reason that this is really the most appropriate answer is if we continue to explain why fluoride is important to prevent caries. If it is a religious or a health belief, it won't matter how much time we spend to give this explanation. The client might have other reasons to select or not select the care we're suggesting. The care plan is the next step. In planning dental care, there are many additional factors to consider. The dental professional must use his or her professional knowledge to blend cultural beliefs of the client to the standards of care of the profession. As an example, as you saw, if for cultural beliefs the client did not wish to receive fluoride treatments, this should not be interpreted as the client not wishing or valuing dental care or prevention. The dental professional must acknowledge this belief, yet still maintain the standard of care for preventing caries or reducing risk. The care plan should include activities and counseling which will reduce risk yet fall within the cultural beliefs of that client, such as other methods to improve salivary pH, remove biofilm, reduce sugar, or other nutritional imbalances. Looking in more detail at cultural practices, it might be discovered that the amount of sugars in a diet is extremely high for Native American or Alaska Natives. The care plan might routinely add reducing sugars to address the caries risk. However, If the common dietary practice includes sugar sodas or other sweetened drinks, the care plan must address this in the context of the culture. Always be aware of the relationship of the diet to the healthcare practice. Implementation follows in our process of care and also has a cultural emphasis. The services themselves might not vary, in that the dental professional still might do the same restorative care or preventive care. The dental hygienist might still scale and remove biofilm. The reaction or description of pain may vary between ethnic groups. If it is physiological or psychological or described as karma, the client might not provide the dental professional with the proper feedback during care. Additionally, the response to bleeding may be seen as a topic not discussed for fear of insulting the professional who might have caused the bleeding, or it might be seen as a natural occurrence of healing or a disruptive of life force. It is important to consider the caregiver and the decision maker of a specific culture. The person in charge might not be the client and the patient, and the dental professional must be sure that the preventive measures reach all parties involved. Consider the family culture and language when providing follow-up care or instructions. For Hispanics of Caribbean islands, the decision-making process might be traditionally male, elders, or the oldest female. Implementation of the care plan might need approval and consultation with the family member most in charge of decisions. Eastern European might make decisions in a slow, systematic way. Parents might make decisions, and options are important in the decision-making process. Always remember to look back to decide who is the person in charge of making the decisions. Evaluation is an ongoing process, many times seen as the last step in the process of care, but also a part of each visit in the cycle of care. What if there is non-compliance or lack of achieving the planned outcomes? The dental hygienist and dentist or other professionals must consider possible reasons for this negative outcome. Could it be that there were barriers in language and lack of understanding? Could there be different health beliefs and values? Could it be access or cost? In each of these scenarios, the clinician cannot stereotype the client or assume that the client does not wish to comply. Evaluation requires the practitioner to reevaluate each area, ask questions again if necessary, and use additional strategies which might be more culturally sensitive. Remembering the differences of Western to non-Western values during evaluation is important. If disease results from disharmony or an imbalance of life forces, factors that the dental professional is employing to prompt compliance might not match the health beliefs of that client. Upon evaluation, each outcome should be individually assessed to determine if there is a cultural response preventing reaching the goal. The importance of cooperation and harmony should be considered as motivational points for non-Western values. Documentation is extremely important. It's a very necessary part of our process of care. The record should include any modifications based on culture. Any language barriers or use of interpreters should be documented. Any variations for procedures or cultural beliefs of the client should be recorded. As an example, the documentation for a particular modification in a care plan, the progress notes or care plan, would indicate that the client arrived for a certain care on a certain date. and perhaps stated he or she did not wish to use the interproximal brush, but preferred to use the miswak. The dental hygienist reviewed the techniques and effectiveness of the miswak for this client and determined that it was an equivalent exchange for the product he or she was recommending. The record would document that the miswak was substituted for the interproximal brush for use for this client. If there are multiple dental providers in the office, this documentation will ensure that the modification of the care plan continues. As another example, documentation might also indicate the client arrived with a person who was to be the interpreter. The dental hygienist or dental professional reviewed the background and relationship of the interpreter to this client. The interpreter was a family member of the patient. The dental professional might have determined that the interpreter might not give complete interpretation of the medical history and was concerned for the accuracy of the information. The dental hygienist then recorded the documentation that the patient was reappointed with plans to identify an interpreter for this language that was acceptable to both the client and the office practice, and to begin at a time to completely assess the medical history. This documentation indicates that there was an awareness and a concern for the language barrier and a possible misinterpretation of the recorded information. It also shows an awareness of the need to have cultural and linguistic competence for every client. Communicating across cultures. The thorough process of care for intercultural communication must occur. Each time we approach a phase, we must have evaluation questions to ask. Our first question we ask is this a cultural belief? Could there be explanations of the response or the reaction based on this cultural belief? The second question we ask is, what is the disease prevalence for this group? Did the practitioner miss a cue or a symptom without complete assessment? The third question is more personalized. Do you, as the professional, carry a belief in conflict to this patient? Did you, as the practitioner, say or do something, verbal or nonverbal, that might have created a barrier to this compliance? Answers to these questions allow the professional to begin an open dialogue that is positive and empathetic, trying to establish a common ground to begin care. If you hold a particular stereotype or prejudice at an ethnic or cultural group, you need to become aware of even the minute expressions of this bias. Let us say, for instance, that you do not believe in body tattoos. This, in fact, also influences your first impression of henna for an Indian or Arab cultures. You begin your intra and extra-oral examination and notice a henna tattoo on the female hands. Your nonverbal reaction, perhaps unknown to you, is an eye movement or facial expression to indicate your disapproval with this practice. The client, however, notices, and this reaction could determine that she will never return to the practice. We need to be aware of our cultural beliefs, the prevalence, and our own conflicts. Verbal interactions can be vocal, spoken, or non-vocal, such as Braille or sign language. Our multiple languages can cause misunderstanding and have different interpretations. In addition, our expressions may be misunderstood and have different meanings to different cultures. Our world is now filled with subcultural expressions and shortened structures that can confuse someone of another language. Consider hot, cold, cool expressions and the lost meaning that expression would have for a culture that uses such terms in description of disease or healing process. Consider our expression of laugh out loud or just kidding, and how that would translate to a culture who believes it is rude to laugh out loud or kid. The Hispanic culture might believe that foods are classified as hot and cold, and that illness can be prevented by proper diet. In addition, eating hot or cold foods must be avoided at certain times. When we select words in our nutritional counseling, we must be mindful of not only their literal interpretation, but also the meaning of these words in health beliefs and practices. Use of interpreters is sometimes possible when collecting health histories or explaining preventive strategies. There are many important factors to consider. As we stated before in that short scenario, given a variation in culture, the interpreter should not be a family member. Children might not be privileged to hear the medical history of a parent. Some children might guard the parent in expressing diseases which could be threatening. Some parents might not share the true disease state to the family member doing the interpreting. The interpreter needs full knowledge of medical and dental terms. Oral health literacy needs to be high enough to be understood and explain the questions. The practitioner is establishing a rapport with the client. Therefore, the interaction is to be with the client, and the care is given to maintain eye contact and a presence to the client, not the interpreter. Verbal interactions and use of interpreters become extremely important when there is a language barrier. Consider what would happen if this was you. A Chinese patient who did not speak English was being treated in a dental clinic in a hospital, and there were no interpreters available at first. The dental practitioner was told to just do the work. The patient was nauseous. Then, 30 minutes after the event, the interpreter came. It was discovered that the patient was pregnant. This was not on the medical history. What other greater risk could we be placing our patients at if we do not have a complete medical history with full understanding by either the client or the interpreter? Let's stop and do another poll. What will you do to greet your new patient? You could see from this poll that you readily selected review the chart to determine culture. It is true in our U.S. populations we might extend our hand to shake. If we knew they were Asian, we might nod our head in acknowledgement. The Japanese client might bow. But one of the things to remember here is that in our data collection and our assessment, we should record some of these nuances so that we would know what the proper greeting was. Our nonverbal interactions are a factor of practicing cross-culturally. Consider each aspect of nonverbal, from mannerisms, gestures, proximity, contact, both physical and eye contact, and your own dress code, to consider how this will be interpreted by the client. Each culture has a specific communication style and expectations, which should be acknowledged by the practitioner and clients as care is rendered. Consider the simple variations of interpretation of direct eye contact, bowing and nodding our heads, or in the U.S. our signal of okay, which is not acceptable in some cultures, to realize how many aspects of nonverbal communication can vary and lead to misrepresentation. Our U.S. culture may wish all clients to have direct eye contact as an indication that they understood what we were saying and wished to comply. However, Asians may not want direct eye contact and may tend to believe that direct eye contact is disrespectful, especially to authorities. We must adjust our interpretation of the mannerisms while considering our education presentation or evaluation our results. As another example, a client of Asian culture might arrive to the dental chair and wish to take off her shoes. The dental professional unknowingly might wonder about this practice, and when asked, the client might say it's a form of respect. Cultural competence is a continuum, and it builds on one's ability to go from destructiveness to proficiency. These components are like stairs to move to higher levels as the practitioner learns and applies new skills. Destructiveness would identify actions of which the cultural practices are hurtful or destructive. Incapacity identifies actions or practices given no intention, bias, superior opinions, or no assistance to the barriers. Blindness indicates practices of no action, indicating that none is needed, a thought that all groups are treated the same, as it makes no difference. Pre-competence brings the practitioner to a level of attempting to improve or try some new actions. Competence is a level to accept or respect differences. Proficiency seeks to move the practitioner to the highest level and seeks to add new knowledge, employs providers with a new set of skills, and reviews the delivery of care with cultural competence in the forefront. Because this is a continuum, we might be anywhere along the path as we begin this process. Each level requires careful assessment of what we personally bring to the practice. It, of course, is hoped that we are not at the destructive level to harm someone, but without realizing we might do harm through omission of an action which could bring someone to care. If we were blind to differences, we would treat all clients the same and not modify any care plan for cultural beliefs or practices. It is in itself to prevent clients from continuing this practice or seeking care from a practitioner who would not be sensitive to their needs. Building cultural competence. In all of our practitioners and all aspects of our process of care, it is important to move along the continuum. We begin by learning as much as we can about each culture in our community and our practice. First, we assess our skills, values, and knowledge to be sure that we bring no negative stereotypes or judgment to this process. If new material is needed in different languages or different literary levels, or to increase cultural sensitivity, then that must be addressed. There are numerous cultural inventories or value surveys that can be taken. It might be more interesting to merely look at the cultures of the clients in your practice. Consider what you know about each group as a race and then look deeper into the culture. Asian as a race has many different traditions in Chinese, Japanese, Filipino, Vietnamese, Korean, or Indian. A person born in another country might carry tradition forward or hold on to aspects of his or her heritage. However, one cannot assume that a person has not adopted U.S. or Western beliefs. a Japanese American may hold more Western values over time than a Japanese client who has recently immigrated or holds on to previous cultural beliefs. For each culture, it is wise to explore the people and the relationships, reasoning, communication patterns, and work styles. Each aspect of these topics relates to a culture and is important for us to consider. Start with the generalizations, but these are only a starting point. We cannot oversimplify or stereotype. Let's look at our last polling question. Hispanics are always late to appointments. This is an example of you immediately picked up on the fact that it was a stereotype. Cultural blindness would mean that you took no actions, and it might be your belief, but it in fact is a stereotype that we need to address so that we have open communication. The role of the organization. Is important as we invest in cultural training, reduce misunderstandings, and enhance the quality of care. Each of us has a role to bring forward as we work both in our individual practices, in our community centers, or society in general. A cross-cultural guide is a helpful document that you can create for your own office. This was taken from one of the reference books that is available to you. However, it's very important for you to create your own based on the types of cultures and ethnic groups that you address, and to select some of the information that's important to you, such as greetings, eye contact, personal space, or decision making. There are a series of case studies that are available on the course that's presented on the Online Learning Center. I will do one quickly here. An Nguyen is a 14-year-old female patient and is coming for a recall dental hygiene appointment. Since the practice has many Vietnamese patients in the past, the dental professional is aware to address this patient as An when updating her medical history, remembers to write her first name and then her given name, Nguyen An. Since she is a minor, her mother must accompany on all her visits. They are consistently late due to time orientation and customs in the country. This is not done to be impolite, but they do not follow Western culture. The professional went to the waiting room to greet the client and slightly bowed when calling her name as a sign of respect. The professional purposely spoke in a lower, precise manner while explaining to them that the translator could be arranged to meet any translation needs. Since the practice has an ethnically diverse patient base, they offer this service to their clients. These are things to improve communication. There are other case studies, as I said, that are available on the website. I would like to be able to give you time to ask some questions as we move to the close of this program.